I want you to do me a favor right now. Just take a deep breath in.
And let it out.
Yeah, exactly. It's
Eh,
a completely effortless, a subconscious act, isn't it? It's this incredible mechanical marvel that most of us just take completely for granted.
right up until the exact moment it stops working perfectly.
Exactly.
Yeah.
Welcome to today's deep dive. We're really glad you're here with us. Today, we're looking at a pretty dense stack of textbook excerpts on chronic pulmonary disorders and management strategies.
It is a hefty stack. I mean, it's highly clinical material.
Very dense. But our mission today is simple. We're going to act as your ultimate shortcut to understanding exactly how your lungs function. We'll look at what happens mechanically when they encounter chronic diseases like COPD, asthma, and cystic fibrosis.
And, crucially, we're going to explore the absolutely fascinating medical engineering we use to fight back against these conditions.
Yeah, the engineering part is mind-blowing.
It really is. It's great to be here with you to talk about this. When you look at the pathophysiology and the pharmacological data behind these chronic pulmonary disorders, what really emerges is an incredible story.
A story about resilience, right?
Yes, the sheer resilience of the human body, but also the remarkably rapid evolution of modern respiratory medicine. The way we understand and treat these diseases has it's shifted dramatically, even just in the last few decades.
Okay, let's unpack this by starting with the heavyweight. Chronic obstructive pulmonary disease, or COPD. We hear this umbrella term thrown around a lot.
You hear it all the time in clinical settings.
Right, but fundamentally, COPD is a disease state characterized by an airflow limitation that is not fully reversible. And it typically presents a combination of two very distinct overlapping disease processes.
Emphysema and chronic bronchitis.
Emphysema and chronic bronchitis, yes.
To really grasp the mechanics of COPD, we have to isolate those two underlying conditions first. Let's start with emphysema. In a healthy lung, the alveoli, those are the tiny air sacs. They have a natural elasticity to them. This allows for efficient gas exchange and, really importantly, exhalation.
But in emphysema, the actual walls of those overdistended alveoli are just destroyed.
Exactly. Yeah. The pulmonary capillary bed is reduced, and crucially, the lungs lose their elastic recoil.
Which is where a visual analogy really helps. Think of the alveoli like brand new balloons.
That's a great way to picture it.
When you blow up a new balloon and let it go, it snaps back and forces the air out instantly. But if you blow that balloon up and stretch it out over and over,
It loses its structural integrity.
yeah, it gets baggy. It just can't snap back anymore. Because that tissue elasticity is gone in emphysema, the lungs can't naturally deflate. The air gets trapped.
And that leads to that classic barrel chest configuration we see in severe patients.
Because the ribs actually get fixed in an inspiratory position.
Right, because the lungs are chronically hyperinflated. The really terrifying part is that exhaling is no longer a passive act.
You have to force it.
You do. You have to recruit accessory muscles and use active, exhausting muscular effort just to push the air out of your own lungs.
That sounds exhausting. Just breathing out becomes a workout.
You'd have a massive workout. That structural collapse takes a tremendous amount of energy to overcome, which explains why severe weight loss and profound fatigue are so common as emphysema progresses.
Wow. Okay, now contrast that mechanical failure with the other major component of COPD, chronic bronchitis.
The clinical definition here is surprisingly strict. You're looking for the presence of a cough and sputum production for at least a combined total of 3 months in each of 2 consecutive years.
So mechanically, the airways are just in a state of constant irritation.
Constant. The bronchial walls become thickened and heavily inflamed, and in response, the goblet cells undergo hyperplasia.
Meaning they rapidly multiply.
Exactly.
They basically turn into an uncontrolled mucus factory.
They really do. They produce excessive amounts of thick mucus that literally plugs up the narrowed airways. At the same time, this chronic inflammation impairs the function of the cilia.
Yeah. Those are the mucosal sweepers, right? The little hairs.
Yes, the tiny hairs that are supposed to clear debris out of the respiratory tract, they stop working properly. So you combine the destroyed elasticity and air trapping of emphysema with the mucus-plugged, physically narrowed airways of chronic bronchitis.
And you get a severe, progressive, and highly restrictive limitation of airflow.
Precisely. That's the hallmark of COPD.
When we look at what drives this progressive limitation, environmental exposures are obviously the major modifiable risk factors. Cigarette smoking accounts for an estimated 80 to 90% of COPD cases.
It's by far the biggest driver.
And we also see secondhand smoke, occupational dust, and a growing body of evidence showing that e-cigarettes and vaping trigger lung changes and airway hyperreactivity that closely mirror early COPD development.
Which is a huge public health concern right now.
It is. But here's where it gets really interesting. There's a genetic factor that can trigger this entire destructive cascade without any environmental exposure at all.
Ah, yes. Alpha-1 antitrypsin deficiency.
Right. Can you explain that? Because it blew my mind.
This is one of those genetic variables that completely changes how we view the disease. Alpha-1 antitrypsin is an enzyme inhibitor naturally produced by the liver. Its primary job is to protect the lung parenchyma from injury.
Protect it from what, exactly?
By counteracting neutrophil elastase. That's a destructive enzyme released by white blood cells during inflammation.
Okay, so if you have a genetic deficiency in this protective inhibitor,
Your lung tissue is left completely unguarded. Unopposed elastase just eats away at the lung tissue. Because of this, even a young person in their 30s who has never smoked a day in their life can rapidly develop severe lobular emphysema.
that is just a stark reminder of how much our baseline genetic makeup dictates our susceptibility to structural damage.
It really is.
Now, before we move away from COPD, there's a clinical reality in managing these severe exacerbations that seems totally counterintuitive to me based on the reading.
The oxygen therapy protocols.
Yes. Let's say a COPD patient comes into the ER, they're hypoxic, their oxygen saturation is dangerously low, and they're struggling for air. My instinct would be to just put them on 100% pure oxygen. Why is that actually a terrible, potentially lethal idea?
It's known as the oxygen paradox, and it requires incredibly careful clinical management. The goal of oxygen therapy is always to increase the partial pressure of arterial oxygen back to an acceptable baseline.
Right, usually titrating to maintain an oxygen saturation of around 90%.
Exactly. But if you administer an excessively high concentration of oxygen to a patient with severe chronic COPD, you risk suppressing their respiratory drive.
Wait, so by giving them the oxygen they need, their brain actually stops telling them to breathe?
That is the danger, yes. In healthy individuals, the primary drive to breathe is triggered by a buildup of carbon dioxide in the blood.
Okay, that makes sense.
But in chronic COPD patients, their baseline carbon dioxide is often permanently elevated.
Right.
Over time, their central chemoreceptors become blunted to it.
They just get used to the high CO2.
Precisely. Their bodies switch to what we call a hypoxic drive, meaning their primary stimulus to breathe is low oxygen. If you suddenly flood their system with high-flow oxygen, you remove that primary stimulus.
Oh, wow. So their ventilation just slows down.
It slows down, leading to a massive retention of carbon dioxide, a state of hypercapnia. That rapidly shifts the blood pH, causing respiratory acidosis, which can lead to a coma or even death. Managing a COPD exacerbation means walking a very delicate tightrope.
You have to give them just enough oxygen to pull them out of hypoxemia, but not a fraction more, or you'll knock out their autonomic drive to breathe.
That's the clinical challenge, yes.
That is fascinating. Okay, let's look at a totally different kind of airway disease. If COPD is defined by irreversible structural damage, asthma introduces a totally different mechanical problem: sudden reversible inflammation.
Yes, asthma is a heterogeneous disease defined by chronic airway inflammation and intense airway hyperresponsiveness.
And the key word there is reversible, right?
What's fascinating here is the sheer speed and complexity of the cellular cascade during an acute asthma attack. The underlying pathology is this reversible, diffuse airway inflammation.
So what triggers the actual attack?
When a susceptible person encounters a trigger, whether that's an allergen like pollen or animal dander, or even a non-allergic irritant like cold air or a viral infection, the immune system wildly overreacts.
It goes into overdrive.
It does. The airway is flooded with IgE antibodies, which bind to mast cells in the mucosal lining, essentially priming them like biological landmines.
And when those mast cells actually degranulate, they release a massive flood of chemical mediators. The texts mention heavy hitters like histamine, prostaglandins, and leukotrienes.
Those mediators are what drive the acute physical crisis. They cause sudden, severe bronchoconstriction.
That's the tightening.
Right, the smooth muscle bands wrapping around the airways spasm and squeeze tight. Simultaneously, the mediators trigger intense localized vasodilation and capillary leakage, causing the airway walls themselves to swell with edema.
And then there's the mucus.
Finally, yes, they hyperstimulate mucus secretion. The airway is being squeezed shut from the outside by muscle, swollen shut on the inside by tissue edema, and physically blocked by thick mucus plugs.
Which perfectly explains the classic clinical presentation. The sudden chest tightness, the profound shortness of breath, and that signature high-pitched wheezing sound as the patient tries to force air through those tiny restricted tubes.
It's a very mechanical obstruction.
But there's a terrifying complication we need to talk about. Status asthmaticus. This is a severe, rapid onset exacerbation that simply doesn't respond to conventional rescue therapies.
It's a true medical emergency.
And there's a vital warning sign here that everyone should know. We inherently associate severe asthma with loud wheezing, but if someone is in the middle of a severe attack and that wheezing suddenly disappears, that's actually the worst possible sign, right?
It is an ominous clinical finding, often referred to as a silent chest. If the obstruction worsens to the point where the wheezing suddenly stops, it doesn't mean the bronchospasm has resolved. It means the airflows become so profoundly restricted that there isn't even enough air moving through the bronchi to generate acoustic turbulence. It's an immediate indicator of impending respiratory failure.
Wow.
The patient is no longer exchanging enough gas to sustain life, and massive medical intervention is required instantly.
It's a full-blown emergency. But thankfully, proactive asthma management has evolved to prevent patients from ever reaching that silent chest phase.
Absolutely.
A massive part of that is giving patients the tools to quantify their own respiratory function, specifically through the peak flow meter. This is a handheld device that measures the peak expiratory flow rate.
The highest velocity of airflow during a forced expiration. You take a deep breath and blast the air out as hard and fast as you can.
And why is that so important for a patient to do at home?
It provides purely objective data, which is vital because a patient's subjective perception of their airway narrowing is notoriously unreliable.
Yeah.
You establish a personal best baseline when the patient is completely healthy and stable. From there, the meter's readings dictate a written action plan.
Like a traffic light system.
Exactly. If a patient is blowing between 80 and 100% of their personal best, they're in the green zone, meaning maintenance therapy is working.
If they drop into the yellow zone, blowing between 60 and 80%, that's the objective warning. The airways are narrowing, even if they don't feel breathless yet, and they need to initiate their quick-relief bronchodilators.
And if they hit the red zone, blowing under 60%, it's an immediate medical alert requiring emergency steps.
It's such an elegant way to turn a subjective feeling of chest tightness into actionable, quantitative data.
It removes the guesswork and empowers the patient. Now, moving from reversible hyperresponsiveness, we encounter diseases where the physical structure of the airways themselves becomes permanently altered, turning the lungs into dangerous incubators.
The mucus traps. Let's look at bronchiectasis. This is a chronic, irreversible dilation of the bronchi and bronchioles.
It's a structural breakdown.
Right, basically, recurrent intense infections and inflammation destroy the muscular and elastic connective tissues of the airway walls. The airways lose their structural integrity and become saccular, forming these dilated, pouch-like abnormalities.
And because the normal clearance mechanisms are destroyed, these pouches become stagnant infected pools, resulting in a chronic severe cough producing copious amounts of purulent sputum and frequently hemoptysis, or coughing up blood.
Bronchiectasis is a devastating condition on its own, but it's also a major respiratory manifestation of another incredibly complex genetic disorder, cystic fibrosis.
Yes. CF is the most common fatal autosomal recessive disease among Caucasian populations. Because it requires 2 defective copies of the gene, if both parents are asymptomatic carriers, they still face a 25% chance with each pregnancy that their child will have the disease.
And the entire systemic cascade of cystic fibrosis all traces back to a single protein mutation, most commonly the delta F508 mutation. This specific mutation affects the CFTR protein, the cystic fibrosis transmembrane conductance regulator.
Which is quite a mouthful, but its job is simple. In a healthy body, this protein acts as a crucial channel, transporting chloride ions across the membranes of epithelial cells.
So what happens when that breaks down?
When that CFTR protein is defective or absent, the transport of those chloride ions totally fails. The downstream osmotic effect is devastating. Because salt isn't moving properly, water isn't following it.
So everything dries out.
The exocrine glands produce incredibly thick, viscous, dehydrated secretions. In the lungs, this utterly paralyzes the mucociliary escalator. The mucus just sits there, physically plugging the bronchioles.
And that stagnant, dehydrated mucus becomes an absolute breeding ground for opportunistic pathogens. Early on, pediatric patients battle staph infections, but as the disease progresses, the lungs are almost inevitably colonized by a highly stubborn bacteria called Pseudomonas aeruginosa.
It's a very tough bug. It forms biofilms, accelerates the structural destruction of the lungs, and is notoriously resistant to standard antibiotics.
Despite all this heavy, progressive pathology, the survival statistics for CF have undergone a miraculous shift. It was once considered a strictly fatal childhood disease. Children rarely survive to adulthood.
It was a very grim prognosis.
But today, the median expected survival age is pushing past 37, with projections hitting 57 and beyond.
That leap in life expectancy represents one of the greatest triumphs of modern pharmacology. Historically, all we could do was chase the symptoms and fight the localized infections. We relied on aggressive, multimodal antibiotic regimens, including inhaled medications like tobramycin delivered straight to the lung tissue.
And the mucolytics.
Right, we also used mucolytics, notably a nebulized recombinant human DNase called Dornase alpha.
Which is such a brilliant biological tool. Dornase alpha doesn't just hydrate the mucus, it actually targets the massive amounts of extracellular DNA left behind by the millions of dead white blood cells that have flooded the lungs to fight the Pseudomonas.
It's fascinating.
It chemically cleaves that DNA, dramatically thinning the mucus so the patient can actually expectorate it.
It's highly effective for symptom management.
Mm-hmm.
But the true paradigm shift, the reason we are seeing patients live into their 50s and 60s, comes down to a revolutionary class of drugs called CFTR modulators.
This is where we stop chasing symptoms.
Exactly. Instead of managing the downstream mucus, these drugs target the defective protein itself. We generally classify them into potentiators and correctors.
So what does this actually look like at the cellular level? How do you fix a broken protein channel?
Well, it depends on the specific genetic mutation. For some patients, the CFTR protein manages to reach the surface of the epithelial cell, but the channel is stuck closed. That's where a potentiator like ivacaftor comes in.
Just opens the door.
Exactly. It binds to the defective protein at the cell surface and physically forces the gate open, restoring the flow of chloride and water.
That's amazing.
But for the vast majority of patients, those with the delta F508 mutation, the problem happens much earlier. The mutation causes the protein to misfold during its creation. Because it has the wrong 3D shape, the cell's quality control mechanisms flag it as defective and destroy it before it ever leaves the endoplasmic reticulum.
So the channel never even makes it to the cell membrane. It's destroyed at the factory?
Exactly the problem. This is where lumacaftor or tezacaftor act almost like molecular chaperones. They physically bind to the misfolded CFTR protein and help it fold into a more normalized 3D conformation. This allows it to bypass the cell's destructive quality control and actually travel to the cell surface.
And then what?
We then combine that corrector with a potentiator to keep the gate open once it gets there. We are fundamentally restoring chloride transport at the cellular level.
So what does this all mean for daily treatment? Whether we're talking about delivering targeted bronchodilators for asthma or inhaled antibiotics for CF, how do we physically get these medications past the upper airway and deep into the failing lung tissue?
You need the right physical toolkit. Inhalers are ubiquitous, but the delivery mechanics vary wildly.
Let's talk about the two primary mechanisms: the pressurized metered dose inhaler, or PMDI, and the dry powder inhaler, or DPI.
The PMDI is the classic L-shaped plastic boot everyone thinks of. It relies on a chemical propellant to shoot an aerosolized mist of medication. The major clinical hurdle with a PMDI is coordination.
Timing is everything.
The patient has to actuate the canister and inhale slowly and deeply at the exact same millisecond. If their timing is off, the aerosol just blasts the back of the oripharynx, gets swallowed, and never reaches the lower respiratory tract.
Which is exactly why valved holding chambers, or spacers, are so critical. They hold that aerosolized mist in a suspended tube, removing the need for perfect hand-breath coordination.
They make a huge difference.
But the dry powder inhaler takes a totally different mechanical approach. There's no chemical propellant at all.
A DPI relies entirely on the kinetic energy of the patient's own inspiratory effort. The device punctures a blister pack of incredibly fine dry powder, and the patient has to execute a rapid, forceful, deep inhalation to physically shear that powder and pull it down into the lungs.
It solves the coordination problem.
It does, but it introduces a new one. If a patient is in the middle of a severe COPD exacerbation and lacks the muscular strength to generate a high inspiratory flow rate, the powder just sits in the device.
They just can't pull it in. Then there's the physical manipulation of the chest to clear out mucus, known as chest physiotherapy, or CPT. In an era of targeted genetic modulators, using gravity and physical percussion seems almost primitive, but it's remarkably effective.
It's a cornerstone of treatment.
It utilizes manual chest percussion, rhythmically cupping the hands and striking the patient's chest wall to send kinetic vibrations deep into the pulmonary tissue to dislodge adherent mucus. You combine that with postural drainage.
Literally positioning the patient in specific gravitational orientations
Hmm.
so the dislodged mucus drains from the smaller bronchioles into the main bronchi to be coughed out.
It's highly effective but physically exhausting for both the patient and the respiratory therapist.
And this is where medical engineering has provided brilliant, high-tech alternatives, most notably high-frequency chest wall oscillation vests.
The shaker vests.
Yes, the patient wears an inflatable garment attached to an air pulse generator. The vest rapidly inflates and deflates, compressing the chest wall anywhere from 8 to 18 times a second.
That's fast.
It is. And that specific frequency actually mimics the natural beat frequency of the pulmonary cilia, creating miniature cough-like shear forces that radically thin and mobilize the mucus, all while the patient simply sits and breathes normally.
And we can't talk about mechanical clearance without mentioning the flutter valve. It might be my favorite piece of simple fluid dynamics in respiratory medicine.
It's a very clever device.
It looks like a standard inhaler pipe, but inside the bowl sits a heavy, high-density steel ball. When the patient forcefully exhales into the pipe, the airflow lifts the ball, but gravity immediately pulls it back down into the cone.
Right.
This creates a rapid opening and closing of the airway. It generates positive expiratory pressure to hold the airways open, while simultaneously sending high-frequency vibratory waves back down the tracheobronchial tree to shatter the mucus bonds.
It's an elegant use of basic physics. And the most fundamental mechanical tool doesn't require any equipment at all. Breathing retraining, specifically pursed lip breathing.
How does that work?
For our COPD patients suffering from severe air trapping due to the loss of alveolar elasticity, we teach them to inhale normally through the nose and exhale very slowly through tightly pursed lips.
By creating that artificial bottleneck at the lips, they're drastically changing the fluid dynamics of their exhalation.
They're generating positive end expiratory pressure. By forcing the air out against the resistance of the pursed lips, the pressure inside the entire bronchial tree increases. That positive pressure acts like an internal pneumatic splint.
A splint for the airways.
Yes. It physically holds those damaged, floppy, small airways open just long enough for the trapped air to fully escape. It immediately slows the respiratory rate, decreases a terrifying sensation of dyspnea, and puts the patient back in control of their own ventilation.
When you step back and look at the entire landscape we've covered today, from the systemic cascade of a single misfolded protein in cystic fibrosis, to the intense, sudden inflammatory storms of asthma, to the slow structural collapse of COPD, you realize just how complex and profoundly fragile our respiratory system really is.
It's incredibly delicate.
And yet, look at the mechanical wonder of the breaths you've taken just over the last 20 minutes while listening to this. Whether you're prepping for a clinical meeting, trying to understand a loved one's diagnosis, or you're just deeply curious about the hidden machinery of the human body, you now have a solid grasp of how these chronic diseases operate and the incredible, evolving ways modern science is fighting back.
This raises an important question as we look to the future. If we connect this to the bigger picture, we're now actively using targeted modulators to correct the literal 3D shape of cellular proteins in genetic diseases like cystic fibrosis. As our understanding of this cellular machinery deepens, it raises a fascinating possibility.
What's that?
Could the targeted therapies we're developing today eventually allow us to biologically armor our airway cells, preventing environmental damage from things like smoke or pollution before conditions like COPD can even take root?
What a thought to end on. It really makes you realize we might just be scratching the surface of what respiratory medicine can achieve. Thank you so much for joining us on this deep dive. Keep questioning, keep learning, and whatever you do today, never take a single breath for granted.